My name is Lynlee Wolfe. I am a maternal fetal medicine specialist at the University of Tennessee Medical Center in Knoxville. Today, I'm going to discuss cardiomyopathy in pregnancy. While cardiomyopathies affect a small portion of pregnant women, they play a large role in maternal mortality and can be seen in routine practice. I'm going to review cardiomyopathies in general, focus on peripartum cardiomyopathy, and hopefully by the end of the presentation, you will feel more comfortable recognizing and caring for a woman with cardiomyopathy. Before we jump into any further discussion, let's talk about why this is even a topic. You may recall from recent news that the United States maternal mortality rate was significantly higher when compared to other developed countries. As you can see here, the country with the closest rate was about half that of the United States. In fact, in 2021, the U.S. maternal mortality rate almost doubled compared to 2018. New headlines being reported every day, it was evident that something needed to be done to change these outcomes. If we look further at the 2023 Tennessee Maternal Mortality Report to the General Assembly, these national numbers reflect what we are seeing here in our state. There was a significant rise between 2019 and 2021. The pregnancy-related mortality ratio in 2021 at 64.9 deaths per 100,000 live births was almost 2 times the prior 4-year average ratio at 35.4 deaths per 100,000 live births. This was in part due to an increase in COVID-19 deaths and the utilization of the Utah criteria. The Utah criteria introduced standardized criteria for review of perinatal suicides and accidental drug-related deaths. Keeping with Tennessee statistics, if you look further into the individual causes of maternal death, it is evident that cardiovascular disease is the most common non-obstetric cause of pregnancy-related deaths. To further explain how maternal deaths are classified, they are broken down into pregnancy-related and pregnancy-associated but not related. A pregnancy-related death is defined as death during pregnancy or with 1 year of the end of a pregnancy from a pregnancy complication, like postpartum hemorrhage or amniotic fluid embolism, a chain of events initiated by the pregnancy, such as an overdose death subsequent to the loss of custody, or the aggravation of an unrelated condition by the physiologic effects of pregnancy, such as preexisting cardiac disorders and decompensation. For the years 2017 to 2021, cardiovascular disease was the leading cause of pregnancy-related death, which was followed by hemorrhage, COVID-19, substance use disorder, mental health, embolism, infection, and others. If we look specifically at cardiovascular deaths and national data from the 2022 Maternal Mortality Annual Report, we can see that almost half, or 48%, of the cardiovascular deaths were due to preeclampsia and eclampsia, followed by cardiomyopathy and other cardiovascular deaths. To be complete and look at these other causes, they included pulmonary hypertension, aortic dissection, conduction deficits and arrhythmias, valvular and non-valvular heart disease, coronary artery disease, and hypertensive disorders. This image is also taken from the 2023 Tennessee report and speaks to when these deaths are occurring. As you can see, nearly 2/3 of the deaths occur in the time frame of pregnancy to 42 days postpartum. However, 1/3 of the deaths occur from 43 days to the 1-year mark, and in fact, some MMR committees have reported an increase in cardiovascular deaths during this time frame. Once the Maternal Mortality Review Committee has established the cause of death, they then decide if it was a preventable death. Preventability is assessed by whether specific and feasible actions, had they been implemented, might have changed the course of the woman's trajectory and led to a non-fatal outcome, as measured on a continuum of good, some, or no chance. 80% of pregnancy-related deaths in Tennessee were determined to be preventable, and 40% of them had a good chance. This means that there could have been an opportunity to change the outcome and allows the committee to identify contributing factors where actions can be considered. In looking at contributing factors for cardiovascular deaths, preeclampsia, a large factor, was delay in inappropriate care. For cardiomyopathy, the contributing factors appear to be related to inadequate assessment of the patient's risk factors, secondary to their history for things like substance use disorder and other comorbidities. Other contributing factors were known cardiomyopathies without addressing appropriate contraceptive plans and patients not adhering to the prescribed medicine regimen. The California Maternal Mortality Review Committee looked at multiple contributing factors in cardiovascular death, and the results were published by Main et al. In the Green Journal in 2015. When evaluating factors from a healthcare provider standpoint, they discovered that 62% of maternal deaths had a delay in response to critical warning signs, 45% had ineffective care plan, 31% had missed diagnosis, 28% had lack of continuity of care, and 9% had failure to consult the appropriate provider. From this, we can learn that appropriate diagnosis and screening can allow for accurate referrals and timely, appropriate management. When looking at individual factors, they deemed that underlying medical conditions were by far the most significant contributing factor. In addition, obesity, delay in seeking care, lack of knowledge of symptoms, and substance abuse were also significant factors related to maternal deaths. So one might ask, why this increase is occurring? The graph above shows data from the most recent vital statistics report from the CDC looking at maternal age and birth rate. As you can see, the 15 to 19 and 20 to 24-year-olds have a fairly significant decline in the birth rate per 1,000 women. There is even a subtle decline in the 25 to 29-year-olds. However, there is an increase in the 40 to 44, 35 to 39, and even a slight increase in the 30 to 34-year-olds. As women age, they have an increased risk for comorbid conditions that can lead to cardiac complications. In addition to the delay in childbearing for their career and their lives, women who were previously unable to conceive are now able, thanks to modern medicine and technology, able to have a pregnancy of their own with some risk. Finally, with the opioid epidemic and the rise in substance use, including smoking and cocaine use, there are multiple causes for acquired cardiac disease. Let us look at a case presentation. This is MM, a 30-year-old gravida 3 para 3 who presented to the emergency room post-op day 7 from an uncomplicated repeat C-section at term with complaints of chest pain, headache, and hypertension. Her vitals were notable for a blood pressure of 151/94, heart rate of 103, respiratory rate of 18, and oxygen saturation of 99%. On physical exam, she appeared in no acute distress, was neurologically intact with 2+ reflexes, and had new onset 2+ edema. Lab values were notable for mild anemia, normal platelets, normal liver and renal tests, and a negative troponin, and a BNP of 254. She had no protein on her urine dip. Her EKG was sinus rhythm with a prolonged QT and borderline right axis deviation. Chest X-ray was suggestive of viral pneumonia. Automatically, with an elevated blood pressure on post-op day 7, eclampsia would be at the top of the list. We might even evaluate in the ED, think that she is not severe given her mild range blood pressures and lack of significant proteinuria, and discharge her home. One might even call her mild pre-E with a pneumonia and perhaps send her home on antibiotics since she was afebrile. But what if we also ordered the echocardiogram because of that abnormal BNP? The echocardiogram was ordered, and it showed mild to moderately increased left ventricular wall size with severely reduced systolic function and an EF of 20 to 25%. There was severe diffuse hypokinesis. The left atrium was moderately dilated, and there was a small pericardial effusion. Clearly, this changes our differential. By having an increased index of suspicion and ordering the echocardiogram, we have paid attention to the clinical warning signs, made an appropriate diagnosis, and can now give appropriate and effective care and consult the appropriate care team for what appears to be the diagnosis of peripartum cardiomyopathy. So let's talk a little more about cardiomyopathy. Cardiomyopathy is considered a group of disorders in which the heart muscle is structurally and functionally abnormal in the absence of other diseases that could cause observed myocardial abnormalities. Diseases such as coronary artery disease, long-standing hypertension, valvular heart disease, and congenital heart disease. Cardiomyopathies can be acquired or inherited. The two most common types of cardiomyopathy are dilated and hypertrophic. Dilated cardiomyopathy can further be broken down into peripartum and non-peripartum. In obstetrics, peripartum cardiomyopathy is commonly characterized under dilated cardiomyopathy given the echocardiogram findings. Non-peripartum cardiomyopathy can be secondary to multiple things including alcohol and drugs, viral infections, and inflammatory diseases. Hypertrophic cardiomyopathy can also be broken down into primary and secondary, with secondary causes including long-standing hypertension, use of drugs, and valvular heart diseases such as stenosis. If we look at this cartoon schematic of a normal heart on the left, you can see the right ventricle in blue and the left ventricle in red. These pictorial drawings represent a rather simplistic but accurate version of the physiologic function in cardiomyopathies. For dilated cardiomyopathy in the middle, it is evident that the left ventricle is enlarged. The heart muscle appears thinner and therefore less effective, in turn decreasing the overall amount of blood that can be ejected out of the aorta to the body. For hypertrophic cardiomyopathy on the far right, the left ventricle muscle wall is significantly thickened, therefore reducing the overall size of the left ventricle and the amount of blood that can be pumped out. Peripartum cardiomyopathy is the most common type of cardiomyopathy seen in pregnancy, and according to a study out of Kaiser, it represented 68% of all women with heart failure. The second most common was non-ischemic dilated cardiomyopathy at almost 7%, followed by hypertrophic cardiomyopathy at 3.5%. Before we get further, let's take a moment to review the physiologic changes in pregnancy that will impact cardiac function. In pregnancy, there is an increase in blood volume of about 30 to 50%. Due to this increase, as well as an increase in heart rate, cardiac output increases by 30 to 50% with a peak around 28 weeks gestation. The body meets this increase by decreasing systemic vascular resistance by approximately 30%, which in turn decreases blood pressure. Pregnancy is considered a hypercoagulable state, and even more so in the postpartum period. Finally, there are significant fluctuations in volume status during labor and delivery, which can really be a stress on the heart. I included this graph for pictorial representation of the changes we just described. I like this picture for two reasons. First, as you can see, the increase in blood volume peaks somewhere in the second or early third trimester. If there is an underlying cardiac problem, this is the time frame where you would expect decompensation. So, if a pregnant mother presents with signs of heart failure during pregnancy, especially if it's in the second or early third trimester, one might expect it to be related to an underlying or preexisting cardiac condition. Versus, when heart failure develops postpartum, it would point more towards a peripartum cardiomyopathy. The other important findings from this graph is to point out that the physiologic changes of pregnancy do not return to normal until about 6 months postpartum. This drives home the need for increased awareness and a higher index of suspicion for anyone who has delivered within the last year. Even basic shortness of breath with bilateral findings on imaging should raise a flag. Without having that high index of suspicion, tests are not ordered and the diagnosis is not made, potentially leading to a pathway of increased maternal mortality. Let's take a deeper look into the individual types of cardiomyopathy, starting with hypertrophic cardiomyopathy. When we think of hypertrophic cardiomyopathy, we often think of increased size of the left ventricular outflow tract, creating left ventricular outflow obstruction. However, the hypertrophy can be of any wall within the ventricle. Often in pregnancy, because of the increased plasma blood volume and increase in left ventricular filling, the obstruction improves, and therefore pregnancy is generally tolerated well. Women may still experience symptoms such as dyspnea, heart failure, arrhythmia, chest pain, dizziness, and syncope in up to 48% of pregnancies, especially if they were symptomatic prior to pregnancy. It is also critical to remember that if hypovolemia occurs, this could decrease filling volume and worsen the obstruction. So if there is a significant postpartum hemorrhage, these patients could be at risk. The mortality rate is quite low, and if they come into pregnancy on a beta blocker, we will often continue that medication or perhaps even start a beta blocker in pregnancy for symptomatic relief. The second big classification is dilated cardiomyopathy. 50% of dilated cardiomyopathy is considered idiopathic, and the other 20 to 35% inherited. This picture was borrowed from the Verywell webpage and is a cute schematic showing potential causes. Some of these we've mentioned previously, such as coronary artery disease, autoimmune disease, and the use of alcohol, drugs, and cocaine, infections, long-standing hypertension, valvular disorders, and even nutritional deficiencies such as selenium. And finally, our main topic of discussion is pregnancy. To be complete, I've included other rare causes of cardiomyopathy that may be encountered during pregnancy. These include restrictive cardiomyopathies, which can be seen in autoimmune conditions and fibrosis, preexisting left ventricular noncompaction syndrome, arrhythmogenic right ventricular cardiomyopathy or ARVC, and Takotsubo cardiomyopathy, which is diagnosed when the heart muscle suddenly becomes weak and most commonly follows severe or emotional physical stress. This condition is temporary, and most people will recover within 2 months. I've seen this in pregnancy twice in my career, both times related to sepsis and profound hypotension, with resultant recovery shortly after discharge. Now, let's focus on peripartum cardiomyopathy. If you recall, it's most commonly classified under dilated cardiomyopathy due to the echocardiogram findings of global hypokinesis. It must be diagnosed within 1 month before delivery and up to 5 months after delivery. Only 7% is diagnosed prior to delivery, and approximately 60% will be diagnosed in that first 2 months after delivery. The incidence depends on geographical location. It has been reported to be as high as 1 in 100 in Nigeria and as low as 1 in 20,000 in Japan. According to UpToDate, the incidence in the U.S. is somewhere between 1 in 1,000 to 1 in 4,000, but the actual true incidence is likely unknown since mild cases can go undiagnosed and may recover without any treatment. A variety of definitions have been used to identify peripartum cardiomyopathy. The current definition was developed by the 2010 European Society of Cardiology Working Group on Peripartum Cardiomyopathy and is the most widely used. It was reaffirmed and included in the 2018 European Society Guidelines and in a position statement from the Heart Failure Association of the European Society of Cardiology study group. The definition is broad as they sought to avoid underdiagnosis, and all three conditions must be met. First, the heart failure must develop in the last month or within 5 months following delivery. Second, the absence of another identifiable cause of heart failure. And finally, left ventricular systolic dysfunction with an LV ejection fraction less than 45% with or without left ventricular dilation. As we mentioned previously, while it is generally classified under dilated cardiomyopathies, there does not have to be dilation. No single unifying cause for peripartum cardiomyopathy has been identified. It is most likely multifactorial in origin, including a combination of inflammation, angiogenic imbalance, and vascular damage. Multiple contributing pathogenic factors have been identified. Experimental research suggests that in the setting of pregnancy-related maternal cardiovascular changes, these multiple factors result in a common final pathway with enhanced oxidative stress, cleavage of prolactin into an angiostatic prolactin fragment, and impaired vascular endothelial growth factor signaling because of increased sFlt1, all leading to endothelial damage and physical damage to heart muscle. This graph is taken from an article in Circulation on peripartum cardiomyopathy and shows the biologic plausibility for prolactin and sFlt1 to play a role in the development of peripartum cardiomyopathy given the timing and rise of these factors. As you can see by the red line, prolactin and sFlt1 increase sharply with the subsequent rise in the diagnosis of peripartum cardiomyopathy. If it were to be related to cardiac output alone, then the timing and diagnosis would be much earlier, as the peak for the black line, cardiac output, is much sooner. While etiology is still in question, there have been some clear risk factors identified. The extremes of age, including women over the age of 35 and young teenagers, African descent, multiple gestations, multiparity, preexisting diabetes, hypertensive disorders, whether it's chronic or pregnancy-induced, substance use disorder, including smoking and cocaine use, and malnutrition, especially selenium deficiency, have also been suggested to play a role for some people or in some countries. The clinical presentation of peripartum cardiomyopathy is variable, but similar to other forms of systolic heart failure. Patients most commonly complain of dyspnea. Other typical symptoms include fatigue, orthopnea, edema, palpitations, cough, and chest pain. Initial diagnosis may be delayed since many of these symptoms occur normally in pregnancy and postpartum. There are numerous ways to classify the severity of heart failure. There are also cardiac risk assessments specific to pregnancy, such as CARPREG and Zahara. Since the New York Heart Association classification is so widely known and accepted, it is the most used classification system in pregnancy. There are 4 stages based on function and physical limitation. Class 1 has no symptoms and can perform ordinary physical activity without limitations. Class 2 has mild symptoms and slight impairment in physical activity, but no symptoms at rest. Class 3 has marked limitation on physical activity, even with less than ordinary activity due to their symptoms, but they are comfortable at rest. And Class 4 is unable to carry out any physical activity. They have severe limitations and symptoms are present even at rest. Patients with preexisting cardiac disease should be classified at the beginning of pregnancy. About 40% will begin as Class 1, and anywhere from 15 to 50% will deteriorate. Patients who present in the later stages should have preconception counseling if possible or referred to maternal fetal medicine as soon as possible in pregnancy to optimize outcomes. When it comes to diagnosis, obviously a high index of suspicion is key. Diagnostic tests that aid in the diagnosis include an EKG, which helps to rule out other conditions in the differential, such as myocardial infarction. EKG abnormalities can be found in up to 50% of patients with peripartum cardiomyopathy, but a normal EKG does not exclude the diagnosis. EKG findings are typically nonspecific and can include sinus tachycardia and nonspecific ST and T-wave abnormalities. Obviously, echocardiogram is needed since ejection fraction is part of the diagnosis. The echo generally reveals a global reduction in left ventricular systolic function with an EF less than 45%. The left ventricle is frequently, but not always, dilated. Echo might also show left atrial enlargement, left ventricular or left atrial thrombus, dilated right ventricular hypokinesis, mitral or tricuspid regurg, and occasionally a small pericardial effusion. BNP, or brain natriuretic peptide, or N-terminal pro-BNP, is also important in the diagnosis as it plays a role in both the diagnostic and prognostic indicator depending on the level. I wanted to add a little more information on BNP. It is a neurohormone specifically secreted from the cardiac ventricles in response to ventricular volume expansion and pressure overload. BNP level of less than 100 picograms per milliliter is considered normal. As we know, pregnancy is a state of physiologic volume overload. Despite an increase in the left ventricular wall mass and end-diastolic dimensions during normal pregnancy, BNP levels remain stable throughout gestation and postpartum period, albeit slightly above normal. In a longitudinal study of plasma BNP levels during pregnancy when compared to non-pregnant, age-matched controls, the median level of BNP was noted to be 19 during pregnancy versus 10 in the non-pregnant state. As you can see, the trimester-specific levels do not vary significantly. BNP levels stay well within normal range during the uncomplicated pregnancy. However, significant elevations are seen in patients with hypertensive disorders, including preeclampsia. Levels greater than 100 are not normal, and further workup should be considered. Complications that arise from peripartum cardiomyopathy are similar to those of heart failure, including the risk for arrhythmia, which can be severe and lead to sudden cardiac death. The heart failure itself can lead to pulmonary edema, which can also lead to death. If ejection fraction is severely reduced, it can lead to cardiogenic shock. Due to poor wall motion, there is a high risk for thromboembolism should a thrombus develop. And finally, hypoxia and stroke. Many of these can be mitigated when recognized, which takes us back to the whole reason we're talking about this today. By recognizing and treating them appropriately, there is an opportunity to change outcomes and hopefully prevent maternal deaths. The treatment algorithm is somewhat complex, especially if the diagnosis is made during pregnancy. After delivery, treatment recommendations follow specific guidelines outlined by Heart Failure Guideline-Directed Medical Therapy, or GDMT. This includes 4 pillars: an ACE inhibitor or an angiotensin receptor antagonist, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. Under GDMT, the ACE or the ARB helps the heart use the strength it has to work more effectively. The beta blocker is used to maintain normal heart rate and maintain heart contractility. The mineralocorticoid receptor antagonist works at the level of the kidney and with remodeling of the heart muscle. And the SGLT2 inhibitor reduces the work on the heart. Diuretics also play a large role in reducing fluid retention and overall volume. I really like this algorithm from Up to Date, but the slide is a little busy, so I've broken it down into the next couple of slides for pregnant and non-pregnant. When diagnosed in pregnancy, the first step is to determine maternal stability. If she is not stable, she should be sent to a higher level of care, and this will be discussed elsewhere in a critical care lecture. If she is stable, the goal is to optimize medication for mom and plan delivery in pregnancy. ACEs and ARBs, SGLT2, and mineralocorticoid receptor inhibitors are contraindicated, and substitution can be made in conjunction with cardiology. Beta blockers, diuretics, vasodilators, and inotropes can be used. A typical regimen may include a beta blocker, MDIR, and hydralazine. Delivery can and should be delayed depending on maternal symptoms. But given the timing of diagnosis in the last month of pregnancy, often once mom is optimized and stabilized, delivery can occur hopefully at term, 37 weeks, and by a vaginal delivery. If the diagnosis is made after delivery, again, the first step is to determine hemodynamic stability. Transfer to a higher level of care where adequate support is available should always occur because if you remember, not recognizing severity of disease and failure to refer and consult were contributing factors in maternal deaths. If the patient is deemed stable, we can then look into whether or not she is going to breastfeed. If the mom is planning to breastfeed, the basic mainstays of guideline-directed medical therapy can still occur. While we do not use ACE inhibitors in pregnancy, there have been studies to support the use with breastfeeding. Therefore, she can receive the ACE inhibitor, beta blocker, as well as the mineralocorticoid receptor antagonist. In terms of diuretics, we are often worried about the use of diuretics in breast milk supply. In this situation, there is a critical need for diuresis, and the benefit for the mom is substantial. Diuretics should not be withheld. For women who are not breastfeeding, preferred guideline-directed medical therapy would be instituted and includes the use of an ARNI, which is the angiotensin receptor blocker, along with neprilysin inhibitor, with the preferred medication being sacubitril valsartan, or Entresto, and the use of the SGLT2 inhibitor with the preferred medications being empagliflozin or dapagliflozin. This chart, also from Up to Date, is a comprehensive overlook of all medication used in standard GDMT for heart failure. As you can see, there's preferred medication in each category and the addition of the ARNI and the SGLT2 inhibitor. But what about bromocriptine? The use of bromocriptine is a topic of debate. Bromocriptine acts by blocking the release of prolactin from the pituitary, which is theorized to potentiate peripartum cardiomyopathy. Some experts advocate using it routinely, but this depends on where you are located. In North America, the use of bromocriptine is viewed as experimental, as noted in the 2020 review by North American peripartum cardiomyopathy experts. In contrast, European experts suggest the use routinely, as reflected by the 2018 European Society of Cardiology Guidelines for the Management of Cardiovascular Disease during pregnancy, which included the recommendation for bromocriptine use, albeit a weak recommendation. Within the current published literature, the studies are mixed. The REBIRTH, or Randomized Evaluation of Bromocriptine in Myocardial Recovery Therapy trial, is currently going, and we will await these results for further information. We are not currently using it as standardized of care, but would not hesitate to use it in certain situations where the mother was not planning to breastfeed. The rate of survival for peripartum cardiomyopathy is significantly better than other forms of cardiomyopathy. In this survival curve, taken from up to date, you can see the significant difference in survival for peripartum cardiomyopathy compared to other forms of cardiomyopathy. Given the high rate of improvement of left ventricular function during optimal heart failure treatment, early placement of a surgically implanted cardioverter defibrillator, or ICD, in patients with newly diagnosed peripartum cardiomyopathy is not appropriate. However, a wearable cardioverter defibrillator may be useful to prevent sudden cardiac death during the first 3 to 6 months after diagnosis, especially in patients with EF less than 35%. If severe left ventricular dysfunction persists, despite 6 to 12 months of optimal medical therapy, implantation of an ICD is recommended. Cardiac transplantation is reserved for patients where mechanical circulatory support is not possible or desirable, or for patients who do not recover after 12 months. But what if they do recover, and can we predict who will recover? There are some prognostic indicators that help determine the likelihood of recovery. Recovery is typically better for patients whose EF is greater than 30% at diagnosis, have lower lab values for BNP and troponin, and who have a left ventricular end diastolic diameter of less than 6 centimeters on echo at the time of diagnosis. Over 65% of patients will have recovery by 6 months, with the EF normalizing to greater than 50%. Counseling of the next pregnancy is heavily impacted by recovery and ejection fraction at the time of diagnosis. If they recover within 6 months and the initial ejection fraction was greater than 25%, it is reasonable to consider another pregnancy. However, ejection fraction less than 25% at diagnosis carries a poor prognosis in the next pregnancy, even if they recover. And when the ejection fraction has not recovered, subsequent pregnancy should be discouraged. If the EF remains less than 50%, the rate of progression in a subsequent pregnancy is over 50%. But even with a normalized ejection fraction, counseling is required, as there is still the potential for recurrence. The mortality rate is high and can be up to 50% if they have ongoing and poor cardiac function. Referral to MFM should occur ASAP if they are pregnant to discuss pregnancy options, and consideration for termination should be discussed. Contraceptive counseling is imperative for all patients at the time of diagnosis. I wish we could say that peripartum cardiomyopathy is preventable. Unfortunately, to date, we do not have the ability to predict who will be affected, and therefore, we do not have preventative measures. However, we can attempt to mitigate the complications by effective screening, appropriate diagnosis, and counseling. If a patient has a preexisting cardiomyopathy, optimizing the pregnancy is imperative for good outcomes. You should obtain a baseline EKG and echo. Depending on the echo findings, they may need an echo every trimester or when new symptoms arise. You should also get a baseline BNP and monitor it every trimester. Depending on EF and symptoms, you may consider a Holter monitor. And finally, anticoagulation should be considered if the EF is less than 35% or if there is a significant arrhythmia. Care should always be in conjunction with MFM or cardiology. With pregnancy optimization, ideally, patients would get to term. But remember, maximum blood volume occurs early in the 3rd trimester, and there is a possibility to decompensate at any point. If new symptoms arise and testing suggests progression of cardiac dysfunction, early delivery may be indicated after optimizing for fetal outcomes. In general, C-section is reserved for obstetric indications. And while vaginal deliveries are ideal, if you remember the significant hemodynamic changes during labor, it may be prudent to consider an assisted vaginal delivery to avoid Valsalva and further strain on the heart. Regional anesthesia is ideal to avoid pain and increased heart rate. A slow epidural is best, and CSE or spinal should be avoided to prevent the rapid drop in blood pressure. I like to include information for the nurses caring for these patients in labor. First, it is important to maintain heart rate, as bradycardia can lead to decreased filling and decreased cardiac output. Maintaining steady blood pressure is vital and goes along with the slow epidural. Monitoring for pulmonary edema comes with having a high index of suspicion, monitoring oxygen saturation throughout labor, and performing a regular physical lung exam to listen for crackles. Finally, it is reasonable to use telemetry in labor, monitoring for signs of ischemia or arrhythmia, especially in those patients with lower EF. In the postpartum state, strict eyes and O's are vital to determining fluid status and overload. The same principles are important, monitoring pulse ox and telemetry for at least 24 hours after delivery or until major fluid shifts have occurred. In patients with current heart failure, you should consider prophylactic anticoagulation for both vaginal and C-sections, especially when the EF is less than 30%. We also recommend keeping them for at least 3 days after delivery and often 5 days as necessary. The data on breastfeeding is mixed. Evidence is scarce and mainly poor. According to some expert groups, breastfeeding should be discouraged when the ejection fraction is severely reduced, and especially in New York Heart Association Class 3-4 patients because of the high metabolic demand of the heart. This would also allow for optimal drug treatment, including the ARNI and SGLT2 inhibitor and possibly bromocriptine. Yet we all recognize how important breastfeeding is to the patient and to the newborn, and in at least one registry study where 37 of 55 patients chose to breastfeed, none of them had adverse maternal effects, and the rate of recovery of left ventricular function was higher in lactating versus non-lactating women. So the topic is still debatable. The World Health Organization suggests breastfeeding as it is best for the infant. The only other recommendation is from the 2018 European Society for Cardiology Guidelines, where they suggest that prevention of lactation be considered in patients with severe heart failure because of the potential effects of prolactin subfragments and the high metabolic demands of lactation and breastfeeding. International research is continuing to establish efficacy and safety of pharmacotherapy in peripartum cardiomyopathy. That was a lot of information. After today, I hope you have a better understanding of cardiomyopathies in general and would feel comfortable taking care of or initially starting the workup for women with preexisting cardiomyopathy. And of utmost importance is recognizing the symptoms and diagnosing peripartum cardiomyopathy, allowing for adequate treatment and perhaps prevention of maternal deaths. In conclusion, cardiomyopathy is a treatable condition with specific pregnancy, delivery, and postpartum considerations and recommendations. Peripartum cardiomyopathy is a diagnosis of exclusion, and the etiology is unknown. When recognized and treated appropriately, poor outcomes may be preventable. There are defined treatment regimens, and everyone should receive the appropriate medication depending on their delivery and breastfeeding status. While prevention may not be possible, recognizing and treating may be the key to decreasing morbidity and mortality. High index of suspicion and attention to symptoms for up to 1 year postpartum is necessary. Future work to address and resolve racial disparities in maternal health and peripartum cardiomyopathy is vitally important. Consideration for anticoagulation and wearable defibrillators is important as these may change outcomes. And finally, we must not forget the contraceptive plan in anyone with peripartum cardiomyopathy or pre-existing cardiomyopathy. Thank you.